And now for today's program. Dr. Martha, and I hope I get this right, I've been practicing, Sajatovic, is professor of psychiatry and neurology at Case Western Reserve University School of Medicine. She's a researcher and educator and also a clinician who has devoted herself to the study and treatment of traditionally hard-to-treat populations with central nervous system disorders. Dr. Sajatovic, her research interests have focused on illness outcomes in mental illness such as depression and bipolar disorder, and in outcomes in a variety of neurological conditions, including dementia. Please help me welcome Dr. Martha Sajatovic.
Thank you very much, Ron, and I really appreciate the honor of being asked to speak to this group. I honestly didn't expect so many people here, but it's wonderful, and I'm going to be talking about a topic that has been a research interest of mine for a number of years, and as we'll discuss, this is really sort of an emerging area in the area of Alzheimer's and other dementias. So is the sound okay? You guys all right back there? Okay. So this is part of a discussion that we hope to be able to continue in collaboration with the Alzheimer's Association. This talk is really sort of the kickoff of a larger initiative that we will implement this summer and hopefully be able to potentially even continue into the national arena. So how can we reduce stigma related to Alzheimer's in our community? So let's start with our first slide here. So as most of you are very familiar with, Alzheimer's disease is a growing problem worldwide. In 2016, an estimated 5.4 million Americans have Alzheimer's. That translates into 1 in every 9 people over the age of 65. And then I think what's most pressing and why so many of us have really gotten involved and more sort of energized in recent years is what is going to be happening with trajectory. By mid-century, the number of people aged 65 and older with AD is expected to nearly triple from that current 5.4 million to a count of approximately 13.8 million. So this is really a very rapidly growing global problem and problem in the U.S. Now, I put this slide up here. It's an older slide, and it really illustrates the typical kind of textbook trajectory of what can happen in dementia from early diagnosis and cognitive symptoms all the way to progressive cognitive loss. However, just like anything that is in a textbook, that doesn't really translate into what we see often on an individual level, and there's tremendous variability. So it's important to take this not with just a grain of salt, but with a pound of salt. So we're going to switch gears now and talk about stigma. And I want to first start off with a definition of stigma. So if you look in the dictionary, the definition of stigma is a mark of disgrace associated with a particular circumstance, quality, or person. That's what Webster says. The synonyms that are used to describe it are shame, dishonor, humiliation, a reputation that's a bad reputation. There's certain cliches out there. The stigma of bankruptcy, we don't see that as much anymore, but fill in the blank. What's really important about stigma is that it separates an individual from the rest of society. It is an attribute that puts the individual at a lower level, that they are somehow damaged, less than, or tainted. Let's talk a little bit about some of the terminology that those of us who do stigma research use, because I think it's important to understand the different, not just what stigma is, but how it is manifest differentially in the population. So we think about stigma in sort of 2 main ways. One is external stigma. That's what other people think. And you can have structural stigma, which is external stigma that is sort of institutionalized. That might be things like care access, insurance coverage, For instance, we still fight in the mental health community about getting equitable insurance company for people with mental health conditions compared to physical health conditions. And then there's public stigma, sort of what the general community thinks about given a certain subgroup or a health condition. And then there's this other notion that is absolutely present, which is called internal stigma. And just like our picture here of the young lady looking in the mirror who sees the monster in the mirror, when you hear yourself referred to in negative terms, sometimes very explicitly, often enough, what happens? You start to believe it, right? I must really be that monster, or I must really be terrible. And so that external kind of flows to the person's own self-identity. Now, if we break down stigma, there are 4 kind of very well identified steps in the stigmatizing process. And this is called the social cognitive theory of stigma. It is a theoretical model that we use in stigma research. So there's 4 concrete steps. Step number 1 is there's a signal or a sign. That is, somebody gets marked as a potential target. What could the mark be? It could be a diagnosis, like a mental illness. It could be a physical sign, like an obvious difference in body size, shape, what have you. So that you need to have that sort of external mark or sign. Then step number 2 is that signal prompts other people to apply negative stereotypes. Those of us in this field call that a cognitive framework. So what is it that the thing that comes to your mind when you see that sign? This could be, for example, this sort of stigmatizing statement that overweight people are sloppy or lazy. That's sort of a negative, kind of unvalidated stereotype. Step number 3 is, so you've got the signal, you've got that negative stereotype or cognitive framework, and then step number 3 is the emotional response that the person has. So that could be, much of my work in stigma is related to people who have another brain condition, which is epilepsy. The emotional that might come from that is fear, that maybe the person with epilepsy is dangerous and could hurt innocent bystanders. And then step number 4, the emotional response can lead to behaviors. So just to give you another example that happens in real-world settings is somebody might avoid being in the same room as a person who they know is HIV positive. So their fear or their other emotional response will drive a specific behavior. So that's kind of the stigma model. And here's how it looks if we apply it to Alzheimer's. So remember, I said there was a signal that could consist of symptoms, labels, certain skill deficits, somebody's physical appearance. So that's your sign. Then that leads to that stereotype. So people could have negative stereotypes about that person's functional status or their aesthetics. And then that leads to a certain kind of emotion. That could be pity, it could be fear. You might have discussed, you might have mixed in there some support or willingness to help. That's certainly out there as a testament to this wonderful community and group. But you can see that flow in the cognitive model. And then lastly, that gets translated into the behaviors, the avoidance, the social distancing, the discrimination, and so on. So this theoretical model applies very nicely to what, in fact, we see around the issue of stigma in Alzheimer's. How common is AD stigma? There's some research out there on it, not as much concrete evidence as you would think, though. A 2003 Alzheimer's Society of Canada found that over 80% of people felt they would be looked upon differently if others knew that they had Alzheimer's. we know and we recognize that not all emotional responses are negative. Many people do want to support and do want to help. But a 2014 European study found that 1/4 to 1/2 of people had attitudes that were quite stigmatizing. Actually, this was an interesting survey that looked at stigma with people toward who had depression, who had Alzheimer's, and who had schizophrenia. And interestingly, the survey found that Alzheimer's stigma fell somewhere in between stigma related to depression, people who have depression, and stigma related to people with schizophrenia. So schizophrenia was the worst, depression least, and Alzheimer's in between, which I think is interesting when you think about a condition where we don't actually have that much research. So what are the most common stigma experiences that people who experience AD-related stigma have? The most common negative experience is feeling discounted or marginalized by others. Remember, I said that part of stigma is making somebody feel less than. The other significant component of AD-related stigma is that people don't really know how to handle the person or how to talk to the person. What do you say or not say? And then fear in others was noted in 14% of this survey respondents. Delving into the AD stigma research, what are the drivers? So who are the subgroups that may be more likely to express AD stigma? So that's not people who feel it, but those who sort of express it or are fearful or who have stigmatizing attitudes. Individuals with less knowledge about AD, people who have no or minimal experience. So if they don't know somebody with the condition or have minimal contact. Lower levels of education, which is something we see in many other stigmatizing conditions. Some studies find gender differences, not all, but generally men tend to have more stigmatizing attitudes than women. Again, not all studies. And some studies find age differences, where younger people actually have more stigmatizing attitudes than older people. Now, there are some statistical confounds here, so if you're younger, it's very possible that you may actually have less contact or less experience with somebody with Alzheimer's, so that may be part of what's driving that as well. And then what are the effects of felt stigma on individuals with cognitive impairment? There are plenty of them. Anxiety and depression rates are higher. Worry about what other people are going to say, if or when they know. Loss of social status, embarrassment and shame. People can avoid treatment, deny a diagnosis, kind of flee from care. Some individuals, even if they know about the diagnosis, may choose to keep that a secret. That's very, very common in stigmatizing conditions, is people don't share that with others, or they're very selective in who they share the information with. Social withdrawal and isolation, so people don't go out. You don't want to go out if you're afraid people are going to find something out about you that's going to have negative repercussions. An overdependence on family. So there's a limited number of people who know about the condition where the person can be honest, candid, and feel safe. And then what really unfortunately results often is a diminished quality of life. What about the effects of stigma on family or caregivers? Is there such a thing as trickle-down stigma? Yes, absolutely. The data is pretty solid on that. The most common is exclusion from social interactions. One really lovely qualitative study that's out there on this topic expresses it nicely, that family members, this was some data from spouses, talked about living on the fringe. So if you're part of a couple, suddenly you're no longer recognized as a couple. There was a really interesting study that identified that stigma actually increases burden on caregivers and care partners by close to 20%. So that's pretty remarkable when you think about it, given how difficult it is for care partners and caregivers. For people that are further along in cognitive decline, loved one symptoms, for example, poor self-care and incontinence, can actually be interpreted by others as evidence of neglect. So, you can imagine that somebody who's already burdened feeling that stigma. And then caregivers can become very isolated if the stigma results in lack of support from friends, families, or others. So stigma really has that negative ripple effect. Now, one interesting dimension of AD-related stigma that has gotten more attention recently is the notion of spillover stigma. And what that is the potential negative effects of earlier and earlier diagnosis or even identifying preclinical Alzheimer's. So in 2012, the US FDA approved a molecular imaging tracer that can be used for people who are being evaluated for possible Alzheimer or other types of dementias. The tracer binds to amyloid plaques. This is a characteristic that is seen in the brains of people with Alzheimer's. And subsequent to that, there have been several compounds that have also received FDA approval. So we now have the ability to identify people who are at risk, even if they're not demonstrating symptoms or cognitive decline. What's important to recognize is even though the amyloid is characteristics of AD, its presence cannot be used to definitively diagnose the condition. Many people who do not have dementia have amyloid plaques, but it can identify in concert with some other evaluations people who may be at risk. What the concern is, and there have been a number of opinion pieces and even a little bit of early research on this field to suggest that there can be some spillover of AD stigma for people who are at that earlier phase, given the expansion of the AD spectrum into preclinical phases. So are we, in fact, looking at the possibility that the stigma dial will be moved upstream? And we can see these effects earlier. And potentially, we talked a little bit about some of those negative effects. Could we be sort of defeating our purpose here if we do not address stigma in its early phases? So what I would say, I think the jury's still out, but I think there's some compelling evidence that spillover stigma does exist. So let's talk for a minute about the media. The media has definitely featured Alzheimer's more in recent years. And we use the term in stigma research where we talked about cultural framing, sort of how does our society picture a thing? What's the first thing that pops into your mind when you think about a given condition? So the cultural framing in many popular films is presenting dementia in its more severe stages, or when symptoms that are further along the trajectory occur, such as forgetting family members. Much of the media uses stigmatizing language. One cross-sectional survey found that 16% of newspaper reports on the topic of Alzheimer's clearly used stigmatizing language. So this is definitely an area where we need to learn more and to be able to do more. Now, there's not a tremendous amount of original evidence or research on this topic, which I think is actually kind of astounding. Especially when we think about things like spillover stigmas, we really need to have more evidence. There was a study that was done not too long ago, U.S. research study, almost 800 adults involved. People read one of 9 vignettes. So people were labeled with 3 different kind of theoretical conditions: Alzheimer's, traumatic brain injury, or no diagnosis. And then they were offered 3 options on prognosis, whether the person was likely to get better, likely not to change, or likely to get worse. And then they gave these people that they surveyed sort of different scenarios based on the condition and the prognosis. Very importantly, they actually used a standardized stigma scale to evaluate how people responded to a given vignette. So they would give them a story about a man who was experiencing some cognitive decline, gave them a little bit of background, what their condition was, and whether, based on their interactions with a clinician, they felt they might get better, worse, or stay the same. They looked at the 4 stigma domains. This goes along with that conceptual model that I shared with you earlier. Structural discrimination, that's things like insurance or healthcare access. Stereotypes, those mental images, emotions, and behaviors. This was a representative U.S. sample. Average age was around 47, half women, 77% white. Over half had some exposure to an individual with Alzheimer's, so it wasn't a totally naive population. And what they found was sort of interesting is that expecting to get worse was a more important driver of stigma than a specific diagnosis. And I think that the key point here is that stigma incorporates not only the name of the condition, but what we expect of the condition. And that's where things like the trajectory and the variability of the trajectory are really important. And it's key to communicate the highly variable trajectory. So how do we combat dementia-related stigma, AD and other dementia-related stigma? I will say up front is there's a very limited evidence base on approaches that are specific to AD stigma reduction. However, we can learn from other chronic brain conditions that happen to have also a very heavy stigma load. So those are things like epilepsy, mental health conditions, and intellectual disability. Those are all highly stigmatized brain conditions. And it's also important that we need to identify what actually works. So we need to be able to look at stigma outcomes pre and post when we do a specific type of intervention to see if it actually makes a difference. What are some evidence-based stigma reduction approaches? So these are the ones that are used in other brain health conditions, and we have good reason to believe that they will be effective when used to combat AD-related stigma. Targeted education, so health literacy, teaching people about a specific health condition is absolutely critical. We have to get that information. I heard so much about the kind of information and education that your volunteers do, and that is, you guys are using an evidence-based approach there. That is known to work. Formal coursework in traditional educational settings. So remember what I was saying about young people tending to have higher rates of AD stigma. It's critical that we address the younger population. And one of the great things about addressing the younger population is you're paying it forward. It's going to have a positive effect for years and decades to come. So that's not to say we shouldn't address the whole population and the older people as well, but if we can get the young people and teach them with the correct information, we can make monumental differences. Advocacy and protest. So I'm just using an example, Twitter, so much in the news right now, right? So Twitter has the advantage of being flexible, fast, and capable of being disseminated almost instantly. Other stigmatizing brain health conditions have used social media like Twitter to their advantage. So Twitter can be a good thing. All right, contact-based education programs. These are another type of evidence-based intervention. These combine contact with the person who has the brain condition with a general member of the population or somebody that you're targeting for anti-stigma campaigns. They raise both knowledge and awareness. And what's nice is they deliver the correct information from a person who's credible, who's believable, who's likable. Very, very powerful. Peer programs, that's a sort of an outgrowth of contact-based education. I do a lot of these in my other brain health condition research. So we actually hire peer educators and we train them. They have the experience in living with a brain health condition, and they share their expertise with people who have less familiarity. is very, very powerful. This can be done in informal self-help groups, but even more importantly, we need to embed it into ongoing health care. So rather than just having doctors or other clinicians, we need to have peer educators embedded into our programs. Now, there's very little actual AD stigma reduction research. Our team has been doing a systematic review, and I can tell you that the number of evidence-based interventions is kind of slim. Let me give you a couple of examples of what's out there. Intergenerational groups. There was a study in the American Journal of Alzheimer's Disease that used an intergenerational choir involving people and families who have been affected by dementia with students. And what they found in their outcomes is college students have diminished negative attitudes, increase in positive attitudes, and then the additional kicker bonus was that the person with dementia had less social isolation. So it's a win-win. We're very lucky that we have some intergenerational efforts, intergenerational school in Ohio that has actually been demonstrated to improve student outcomes. I know Dr. Whitehouse is here, and I'm certain if you had specific questions about that, he will share that and fill you in, but this is an evidence-based approach. There was an interesting study that was done recently in Europe using this notion of concept framing in designing effective anti-stigma reduction. So framing is the process of creating a widely understood symbol of reality. So when I say to you some word, whether it's Alzheimer's or epilepsy or depression or tropical heat, something pops into your mind, right? You have this sort of, and often people from the same culture will have that same kind of automatic thought that pops into their head. These are integral to our society and our culture, what most of us think, kind of automatically. So there's some interesting things about frames, is they present sort of in some ways, a narrow perspective, and sometimes at the expense of a more nuanced understanding of a condition or a situation. This European study was done in Belgium. They tested 2 different public service advertisements, or PSA, focused on Alzheimer's. 1,000 individuals in the general public were evaluated. They all used, with different pictures, and you can actually see the pictures there, behind every person with AD is a living person. So they're really trying to stress the humanity and the individuality of the individual rather than a diagnosis. And this gives you some idea of the framing, counter-framing idea. So what they wanted to do was take those automatic thoughts and change them so that the person has a more nuanced understanding or an alternative way of thinking about a given condition. So a couple of examples. Mind-body dualism, very popular and strong in our Western culture. So the idea could be, I think, expressed as, you are not a person if your mind is not perfect. So we put all the emphasis on the mind. The counterframe approach to try would be mind-body unity. So you're composed of a mind, body, and emotion. You're more complex than a cognitive evaluation. Another example is, one framing is when we think about the idea of Alzheimer's, is this negative death and degeneration theme. Sort of the end is here. A more nuanced theme or counterframing theme would be to say, carpe diem. Everyday joys are to be celebrated, and let's enjoy the now. So in this study, what did they found? They found that counterframing was effective, but it's clear that we had a lot of work to do because negative stereotypes, negative drama catches people's attention more robustly than more nuanced approaches. I mean, for those of us who have been following politics or whatever lately, you see that, putting something in very negative terms will often get people's attention. But we need to persevere, and you can actually change that frame if you are persistent and you present it in different scenarios. Okay. Now, there are a number of stigma reduction initiatives out there. Many of them are taking advantage of evidence-based approaches, but we don't necessarily have outcomes data people with dementia speaking out. So there's an Alzheimer's Association early stage advisory group. This is fabulous. This really is that content-based peer education and peer input. We know it's effective in other conditions, dementia-friendly community, personal testimonies, community outreach, all very powerful, promoting earlier diagnosis. Art and physical activity, kind of the more nuanced understanding of what a person is, the mind, the body, and the emotions, so that you can showcase abilities of people with dementia and reconnect through art and music. Other general recommendations is educate the public, and I would advocate that we really, really, really need to target young people, because that's where we're going to have the biggest, most powerful effect long term. More support for individuals in the early stages, stress the variability, sort of, that nuanced understanding of trajectory and prognosis, reduce the isolation of the person with dementia and maintain social contact, give people with dementia a voice. So, classic example is the person goes to see their clinician in a healthcare setting, and the clinician talks with the caregiver, care partner first. So always talk with the individual with the condition and address them directly. Recognize the rights of people with dementia to participate in healthcare planning to the greatest extent that they are able. Be open and direct about AD and AD-related stigma. So we don't have this discussion very often. And recognize that stigma is there. We need to call attention to and criticize the media. This was I thought, as a psychiatrist, this kind of headline is unfortunately still not extinct. Get the violent crazies off our street, 1,200 people killed by mental patients. So, that's the headline that grabs attention. And we need to, when we see that in the media, we have to draw attention to it. We have to criticize it. Other suggestions are to improve the training on AD for primary care providers. They're in the front lines. They're the best ones to make a difference. Screen for depression, anxiety, and other mental health conditions. So we know that mental health comorbidity is very common in people who are having cognitive decline. Many of these mental health conditions are eminently treatable, but we need to screen for them and identify them so that we can, in fact, include that in the care plan, and then increase AD stigma research. So there's kind of a double-edged sword with AD research. In order to get funding for Alzheimer's, we have to stress what a terrible condition this is, right? So we get the funding, but it worsens stigma. So what I would argue is that we have to embed AD stigma research, and there needs to be a portfolio for funding in that direction as well as the biological and other critical therapies that we need. So that's all my slides. I'd like to thank you for your time and attention. I think we have a little time for questions. I think there's a question there. I don't know if you want to try speaking up, or could we get a mic?
Hello, 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 hello.
Have I been asked to meet with the City Club? I have not been asked to speak with the City Club, but I was just telling Nancy Udelson here that about a day after the notice for this talk went out, I got an email from people involved in the geriatric education program at the VA, and sight unseen, they hadn't heard this talk, they wanted me to get on their schedule. So, certainly, and if we look at veterans' health organizations, it does provide care for a number of older people, families dealing with this issue. So I don't think this is an isolated phenomenon. Our research evidence suggests that it's not, that it's pervasive but understudied and underrecognized. The City Club. Well, thank you.
Hi, I'm Paulette
Yes.
Klein. I wondered if you've gotten any recent data from any studies done on the effectiveness of individual sponsors or persons to support versus support groups in helping reduce stigma.
So the question is there evidence to show that support groups can actually reduce stigma? And so we are doing this systematized review of all of the scientific literature. I would say we're about 3/4 of the way through our review at this point. This is part of an initiative that we intend to launch out in collaboration with the association here, who has been very visionary in identifying this as such an important area. But what is absolutely astounding to me is when we look at the evidence base, we actually don't see data. There's an evidence base in other brain health conditions, so I can see this in schizophrenia and I can see this in epilepsy, but I don't actually see pre-post data in Alzheimer's, which is just mind-boggling to me. But we need to collect the data. Other questions or comments? Yes. Dr. Whitehouse.
Thank you. Great talk, Martha. In your research, did you look into or find anything about mild cognitive impairment and the stigma associated with that kind of messy term?
Yes, so the question is, did we look at mild cognitive impairment? So Peter, in line with my previous comments, what I would say is there really is precious little that really looks at quantifying stigma. Very few studies have used standardized stigma scales, and most of what we know about early phases have been from some of these surveys. So the Canadian study predominantly involved people who had either mild deficit or no deficit, and so we see definitely some stigma. This whole notion of spillover stigma, I think, is really fascinating, because if we're going to be entering an era where we will have more evaluation at earlier and earlier stages, and all the evidence suggests that we need to start doing that as we start to look at either lifestyle or biologic therapies that are going to make a difference, we need to address stigma kind of way upstream. So what are people's expectations, and how do they might affect that will impact them personally? Other questions or comments? So the only things I would say is that for a group like this, where you all are educated about AD, you know about this condition, you're advocates, is even though we don't have data, what you are doing when you do that outreach and when you talk to somebody who particularly might be in the early phases or has just been diagnosed, you are actually reducing stigma. It would be great if we could start to embed kind of that program evaluation going forward. I would love to see you guys do that, because I'm not aware that other organizations are doing that. Are we really hitting that target? Yes.
Is there anything being done to roll that out to primary care physicians so they start looking for Alzheimer's disease a little bit sooner or screen? Because I know in our situation, you wouldn't have he wasn't screened and he didn't primary care physician.
Yeah, so the question is, can we roll something out like this where we can address stigma sort of part and parcel with screening for AD or dementia conditions? There is a little bit of research on that, and I didn't share with us too much because of the short time I had today, but studies with primary care providers have identified that primary care providers do often have stigmatizing attitudes and make the decision that they're not going to screen, or they're going to screen in a particular way. So I believe not only is it important that we provide this kind of training about stigma to the general population or lay population, we need to make sure that primary care providers, because they can be a significant barrier. So absolutely true. Stigma doesn't really respect anybody. It's just kind of per se. Yes.
Just a comment. My husband was diagnosed with mild cognitive impairment many, many years ago. And my approach to the stigma part of it was, instead of keeping it to myself and to him, I screamed it from the rooftops. I told everyone we know that there was something wrong with him. And the reason I did that was because his bizarre behaviors, I didn't want our very dear friends and family members saying, "What's wrong with him?" So from the get-go, I said, he's sick. He's got, and if he acts in a strange way, that's what's wrong with him.
Yes.
And never did I encounter any kind of stigma from any of our friends or family. Because I put it right out there.
Yes. So being upfront and candid as you did is definitely a way to reduce stigma. That is helpful, and I'm glad that you didn't encounter friends who didn't understand or avoided you. I can tell you that, unfortunately, some other people have different experiences. I would imagine that there's folks in this room who've had other experiences or have friends who've had other experiences. But that's where it starts, in being candid. Calling the media out when stigmatizing language is used. That's not acceptable. We need to shame them into appropriate language, because using stigmatizing terms just perpetuates the stigma. But good for you. So being upfront, honest is critical. I think there was another question here somewhere.
I think you said a moment ago that primary care providers sometimes stigmatize their patients, and I think the same thing can be said about insurance companies. And my question is, what are the implications for earlier and earlier diagnosis on how the insurance industry treats patients?
So you raised a really excellent notion. So if you remember one of my earlier slides, I talked about external stigma and internal stigma. So external stigma includes general stigma that we see in the population, but also the structural stigma. So institutions actually can get away. If somebody is perceived then less than, you perceive them as less than, then it's okay to give you less than care. And so that's where that structural, institutionalized stigma needs to be addressed. And I believe some of the very similar things that can be done, although one of the things that happens with institutions is many of them will not change unless they're forced to change. So, but we need to start that discussion. We need to raise awareness. And I think it is important to do the research to find out what actually works.
Are you available to stay for a few minutes?
I can stay for a few minutes if anybody has any individual comments that they'd like to make. So thank you so much for your time and your wonderful attention and questions.